Good morning. Let's go ahead and get started with our Grand Rounds presentation. I'm Ken Serenik, Professor of Surgery, and I moderate Grand Rounds and Morbidity and Mortality Conference. We would like to welcome our intern applicants today. I shook your hands. None of them seem to be cold and clammy. You seem to be doing okay. So we know you're academics. We're just trying to see how crazy you are and whether you can fit in here or not. So good luck with the interview process. This morning, it's our pleasure to have Dr. Ismail Jatoi here. Dr. Jatoi is a professor of surgery. He is the chief of the Division of Surgical Oncology. He was recruited 3 years ago to join the faculty and fill that particular position. He also occupies the Dorn Distinguished Chair in Surgery. Prior to coming here, Dr. Jatoi was at Bethesda Naval Institute, where he ran the Breast Institute for the combined military affiliated with USIS. Please help me welcome Dr. Jatoi this morning, who's going to be talking about DCIS.
Thank you very much, Dr. Serenik. So what I'm going to talk about this morning is ductal carcinoma in situ of the breast. But I think this whole issue of lesions like DCIS and precursor lesions has ramifications well beyond breast cancer. In fact, what we're seeing now is a widening in the use of screening technology, surveillance technology, and other means to diagnose precursor lesions. So this has become a major public health issue, going well beyond the issue of breast cancer and breast diseases. So I think this problem of diagnosing DCIS, treating DCIS, this entire problem of ductal carcinoma in situ is really, to a large extent, a problem that we as physicians have imposed on the public. In other words, what we're finding are precursor lesions that we know very, very little about, and we know really very little about how to treat. And now we've seen this dramatic increase in incidence of things like DCIS. And then very briefly, I'll talk about some of the other precursor lesions in a slide. IPMN, dysplasia with Barrett's, associated with Barrett's esophagus. All these precursor lesions are things that in the past we never diagnosed, we never encountered, because we didn't have the technology to do so that we have today. So anyway, so this is a major public health issue, ductal carcinoma in situ, but its ramifications go well beyond breast cancer and encompass other organ sites as well. So the prevailing hypothesis has been that invasive cancer, invasive breast cancer, develops sequentially. In other words, you start out with a normal breast duct. You then develop a hyperplasia. The hyperplasia becomes atypical, and the atypia then forms ductal carcinoma in situ, which then leads to invasive breast cancer. So this is the sequential model, or the progressive model for the pathogenesis of breast cancer. And this is the model that we were all taught from many years ago, beginning in medical school. This is the model that patients will oftentimes read about when they open up women's magazines and get on the internet to try to find out more about their breast cancer or more about ductal carcinoma in situ. And if you rotate in our service the last couple of weeks, this is what you would have heard Dr. Puri and Dr. Lamaris tell their patients is the way breast cancer develops, and this is the significance of DCIS. And you have to believe these guys because they wear long white coats. So everything you hear about DCIS really is part of a spectrum of diseases, starting with normal ducts, going to hyperplasia, atypia, ductal carcinoma in situ, and then invasive breast cancer. So the key here is that we assume that ductal carcinoma in situ is a precursor lesion that invariably leads to invasive breast cancer. In other words, once you have DCIS, things invariably progress to invasive breast cancer. So how did it come about that we decided that DCIS is a precursor of invasive breast cancer that invariably leads to invasive breast cancer. How did we arrive at that conclusion? Well, if you go back and read the medical literature, go back to the 1940s, go back to the 1950s and read the medical literature, what you find is that the whole hypothesis that DCIS, the precursor for invasive breast cancer, really stems from two basic observations. The first observation is that when you excise invasive breast cancer, you invariably find DCIS adjacent to it. So if you excise invasive breast cancer, if you do a lumpectomy, if you do a mastectomy, and you look under the microscope, you'll see invasive breast cancer, and adjacent to that invasive breast cancer, you'll see DCIS. So the logical assumption is that these two lesions are related, that in fact the DCIS was the precursor for the invasive breast cancer that's right next to it. So the juxtaposition of DCIS next to invasive breast cancer in pathological specimens, in histological specimens, led to the belief that in fact DCIS was the immediate precursor to invasive breast cancer, and that all DCIS invariably progresses to invasive breast cancer. The second observation that suggested that DCIS is a precursor to invasive breast cancer is the fact that with simple excision of DCIS, recurrences often occur, and these recurrences are frequently invasive breast cancer. So if you excise DCIS with close margins or positive margins, invariably what you'll find in many instances, you'll find recurrences over the next several years. And many of these recurrences end up being invasive breast cancer. So these two very simple observations, the fact that there's a histological juxtaposition of DCIS with invasive breast cancer, and the fact that with excision of DCIS, recurrences often occur, and that these recurrences are often invasive breast cancer, led to the conclusion that in fact DCIS was a precursor, was an obligate precursor of invasive breast cancer, that if left untreated, DCIS would invariably progress to invasive breast cancer. Now, DCIS is rarely palpable. You can rarely feel or palpate DCIS. Most patients come to our clinic with a diagnosis of DCIS that's discovered mammographically or through screening technology. So less than 1% of DCIS is actually palpable. Now what I want to show you is this slide. And what this slide shows is this dramatic upsurge in the incidence of DCIS that began around 1980. Now what happened in 1980? Well, in 1980, mammography screening was introduced in the United States. So approximately around 1980, we saw the introduction of mammography screening on a population level in the United States. Prior to around 1980, the incidence of ductal carcinoma in situ was about 2 cases per 100,000 women per year. So prior to 1980, the incidence of ductal carcinoma in situ was extremely low. We had about 2 cases per 100,000 women per year. Following the introduction of mammography screening in 1980, we saw this very dramatic uptick, this very dramatic surge in the incidence of DCIS, such that, and again this graph only goes to 1992, but if you were to go ahead and extend this graph to 2012, such that today the incidence of DCIS is 32 cases per 100,000 women per year. So in the 1970s, prior to the introduction of mammography screening, we were seeing about 2 cases per 100,000 women per year of DCIS. Today, 2012, we're seeing 32 cases per 100,000 women per year of DCIS. So there's been a 16-fold increase in the incidence of DCIS that's accompanied the wider use of mammography screening. So as mammography screening increases, the incidence of DCIS has increased. So really, the diagnosis of DCIS is very heavily technologically driven. It's not clinically driven, it's technologically driven. As our screening tests become more pervasive, as screening becomes more widespread, and as our screening tests become more sensitive, the incidence of DCIS has increased dramatically. We've seen a 16-fold increase in the incidence of DCIS since the introduction of mammography screening in 1980. Now, here's a slide that I wanted to point out. So this is a slide from the American Journal of Radiology, which I don't read very often, but this is something that I came across. If you look at this story, it was a clinical scenario. They talked about a 69-year-old woman with a family history of breast cancer and a recent negative mammogram. The clinicians then ordered an MRI, which is far more sensitive than mammography. And guess what? they found DCIS. So what we're seeing then is that, again, as the sensitivity of our screening technology improves, we can expect to see even more and more and more DCIS. So again, the underlying assumption has been that DCIS is a pre-invasive lesion, a precursor lesion that if untreated, invariably progresses to invasive breast cancer. This is an assumption that we've all been inundated with since very, very early on. And we've been left to believe that by removing these precursor lesions, in fact, we should be reducing the incidence of invasive breast cancer and reducing mortality from breast cancer. Well, in the 1980s, there were some studies that were actually very, very troubling and that cast sort of a shadow over that hypothesis. So one of the studies was a study from the Frederiksberg Hospital in Copenhagen. And what these investigators did is they looked at women aged 20 to 54 who died of accidents, nothing related to breast cancer. They died of car accidents, acts of violence. They came into the hospital. They were dead. Autopsies were performed. And the breasts were microsectioned. In other words, they looked very, very carefully at the breast for histological evidence of DCIS. And what they found, actually they looked for histological evidence of anything, LCIS, DCIS, anything. And what they found was that DCIS was evident in 15% of those specimens. So in 15% of women aged 20 to 54, 15% of those women have occult DCIS. They harbor DCIS. Now, that prevalence, 15%, is 4 to 5 times greater than the number of invasive breast cancers you would expect over a 20 or 30-year period. So there's a huge reservoir of DCIS out there. And we don't detect it unless we introduce surveillance technology into the population. Then there was another study by Alpers and Welling. This was published around 1980. This was published in 1985. And what they did is they looked at autopsies of women diagnosed with breast cancer. Now, women who are diagnosed with breast cancer, with unilateral breast cancer, have about a 12.5% risk of developing contralateral breast cancer over about a 20 or 30-year period. Yet these investigators found, when they looked at the opposite breast, again, they microsectioned the opposite breast, they found DCIS in 48% of those specimens. So 48% of women diagnosed with unilateral breast cancer, no evidence clinically of cancer in the opposite breast. If you microsection their breast, you will find in 48% of those women occult DCIS in the contralateral breast. Again, 4 to 5 times greater than the expected number of breast cancers you would expect to develop over a 20 or 30-year period. And then there are two very interesting natural biology studies that were undertaken. One was by David Page at Memorial Sloan Kettering. The other one was, David Page at Vanderbilt. The other one was by David Rosen at Memorial Sloan Kettering. And what these investigators did, they were expert breast pathologists. They went back and they looked at patients who had diagnosis of atypical ductal hyperplasia. Now, the distinction between atypical ductal hyperplasia and DCIS is often problematic. It takes an expert pathologist sometimes to distinguish between the two. And they found instances where the original pathologist had misdiagnosed DCIS and called it atypia. And what they found is in those instances where you had a wrong diagnosis and the DCIS was essentially left behind untreated, you found that breast cancer developed in about 20-25% of cases. So taken together, these three studies, these three histological studies, autopsy studies, pathological studies, seem to suggest that there's a huge reservoir of ductal carcinoma in situ in the population. These studies seem to suggest that DCIS, in fact, is not an obligate precursor of invasive breast cancer. DCIS is not obliged to become invasive breast cancer. In fact, if you take these studies at face value, what they seem to suggest is that only 1 out of every 4 or 1 out of every 5 cases of DCIS progresses to invasive breast cancer. So if DCIS is indeed a precursor of invasive breast cancer, then it's a non-obligate precursor of invasive breast cancer and has a very low threshold about 20-25%, into ultimately developing into invasive breast cancer. Now this is a graph that Bill Anderson was here a couple years to give a grand rounds. So a couple years ago, he and I looked at trends in the incidence of breast cancer in the United States after the introduction of mammography screening. Now, mammography screening starts in earnest at about age 40. Very few women get screening mammography before age 40. And mammography screening essentially stops in the United States at age 80. Very few clinicians order screening mammograms after age 80. So it's between the ages of 40 and 80 that we see mammography screening in the United States. Now, as I said, mammography screening was introduced in the United States around 1980. And so if you look at this lower graph right here, this is the incidence trend or incidence rates of breast cancer according to age prior to the introduction of mammography screening. And what you see is that by the time a woman reaches to be 80 years old, her risk of developing breast cancer is about 363 cases per 100,000 women per year. Now, as you've introduced mammography screening, this is, again, 1966 to 1975, this dark graph. This is before the introduction of mammography screening. This dotted line represents the incidence of breast cancer 1976 to 1985, shortly after the introduction of mammography screening. And these two graphs, or these two lines, represent the incidence of breast cancer today. Okay, so what you find is that as mammography screening became more prevalent in our society, breast cancer incidence rates went up. Breast cancer incidence rates went up, largely because we were diagnosing DCIS. Now, what you would expect, if in fact DCIS is a precursor lesion, you would expect if risks of breast cancer remain constant from 1980 to today, and there's no reason to suggest that they haven't, you would expect that when you stop mammography screening in 1980, stop mammography screening at age 80, the incidence of invasive breast cancer should drop below the levels that they were prior to the introduction of mammography screening. Because remember, if DCIS is a precursor lesion, you've then removed all this DCIS from the population, the risk of invasive breast cancer after age 80 should be lower today than it was in 1975 prior to the introduction of mammography screening. But that doesn't happen. What you see is that in 1980, the incidence of breast cancer in octogenarians was 363 cases per 100,000 women per year. Today, it's about 490 cases per 100,000 women per year. Again, we're talking about risk of invasive breast cancer. And all this time, we've seen more and more and more screening mammography. All this time, we've seen more and more and more DCIS being harvested and removed from the population. Yet, we don't see a concomitant drop in the incidence of invasive breast cancer. So what that suggests, very strongly, is that much of the DCIS that we're diagnosing would never have progressed to invasive breast cancer. So this is another graph, okay? And this graph shows, again, here's the incidence of invasive breast cancer. I'm sorry, the incidence of DCIS. 1980s mammography screening was introduced. Before 1980, the risk of DCIS was 2 cases per 100,000 women per year. As mammography screening has become more commonplace in our society, we've seen DCIS rates go up and up and up and up and up. Today, the risk of DCIS is 32 cases per 100,000 women per year as a result of mammography screening. And it's sort of plateaued at about that level. Now look up here at the invasive cancer risk. It's actually gone up as well. And it's sort of plateaued and it continues to go up. Now there's a slight drop in invasive cancer risk in 2002. But that's been proven not to be because we've diagnosed more DCIS. That's because women stopped taking hormone replacement therapy after the WHI study was reported in JAMA around 2000. So the drop in incidence of invasive cancer around 2002 had nothing to do with DCIS, had to do with the WHI study and the lowering in the use of HRT among women. Since this graph was published, in fact, the incidence of invasive cancer has continued to go back up and is now at about the same level it was before the HRT became an issue. So what we've seen, again, big population level picture, is that we're harvesting more and more DCIS, but we're not seeing a concomitant drop in the incidence of invasive breast cancer. So in 1989, Petra Peters introduced the concept of overdiagnosis. And what she said is that overdiagnosis is a histologically established diagnosis of invasive or ductal breast cancer that would never have developed in a clinically manifest tumor during the patient's normal life expectancy if no screening examination had been carried out. Now, as I said at the start of my talk, the ramifications of overdiagnosis extends well beyond screening mammography. We see overdiagnosis, for example. I can give you some examples, and I'll give it in a slide later on, using endoscopic technology, where we're finding things like IPMN, polyps with dysplasia, Barrett's esophagus with high-grade dysplasia. There are numerous examples where we're finding precursor lesions, and it's very likely to assume that the same story with regards to DCIS is oftentimes repeated in these other organ sites. So what are the ramifications? We're finding more and more and more DCIS, okay? Based on the pathology studies, based on the histological studies, the overwhelming evidence suggests that only 1 out of every 4 or 1 out of every 5 cases of DCIS would progress to invasive breast cancer. Most of these lesions would never progress. So what are the ramifications? Well, the ramifications are that it has a huge impact on quality of life. This is something that we as physicians have introduced in the population. We recommend screening mammography. We recommend surveillance technology. We find things. You take, for example, a young woman who is seduced into getting a mammogram. Okay, she comes in, she's a big ad, goes and gets a mammogram. She feels fine. She's got no lumps. She's clinically asymptomatic. All of a sudden, you diagnose DCIS, and then you tell her, look, you've got DCIS. You've got ductal carcinoma in situ. Carcinoma, okay? Carcinoma means cancer, okay? So what does that mean? She ultimately may have problems getting life insurance. There are reports that women who are diagnosed with DCIS have problems getting life insurance. She may have problems getting health insurance. She may have problems getting a job. Nobody wants to hire somebody with a carcinoma. So it has huge ramifications in terms of quality of life. So for the majority of women who are diagnosed with precursor lesions, with DCIS and other things, their life is adversely affected. In 25% of cases, we're benefiting the patient. In 75, 80% of patients, we're potentially harming the patient by rendering this diagnosis. And it goes without saying that overdiagnosis leads to overtreatment. If, in fact, only 1 out of every 4, 1 out of every 5 cases progresses, that means that for every 4 or 5 cases that doesn't progress, these patients are getting overtreated. They're getting surgery that they don't need. They're getting radiation that they don't need. They're getting systemic therapy that they don't need. And again, the ramifications of this is beyond breast cancer. So I brought up this slide because this is something that was reported in the JNCI a couple of weeks ago. And the implications of this study are somewhat troubling. So what this study showed is that in women diagnosed with DCIS, ductal carcinoma in situ, radiologists are more likely to overcall lesions in the opposite remaining breast or ipsilateral breast if the patient had a lumpectomy. So this is invasive procedures. This is diagnostic mammograms, invasive procedures. And what you can see is that within the first 6 months of diagnosis, there's a huge uptick in these overcalls and these additional procedures. But these overcalls, these additional procedures remain a threat for the rest of the patient's life. Once he's diagnosed with DCIS, the risk of an overcall, the risk of an unnecessary invasive procedure remains high. So what these authors suggested is that for DCIS, we should consider bilateral mastectomy. So again, if you can imagine, if 80–85% of women with breast cancer or with DCIS have lesions that would never progress, these authors are suggesting we consider bilateral mastectomy, which is a huge, huge, huge impact on a patient's quality of life in a condition as benign as DCIS. So here's a table, and I think this is a table that I showed a couple of, I think about 2 years ago when we were talking about surgery for cancer prevention. But I thought I would include it in this talk. So I've emphasized this morning DCIS, LCIS, and the fact that much of this diagnosis represents overdiagnosis. But the same can apply for various other organ sites. We see non-invasive urothelial tumors more and more commonly with cystoscopy. We see cervical intraepithelial neoplasia, and we recommend, of course, excision. We're doing more and more polypectomies, more and more colon resections as a result of identifying adenomas and dysplasias. We're doing esophagectomies as a result of identifying Barrett's-associated dysplasia. Local excisions are very common for leukoplakia. For the pancreas, where we're increasingly finding more and more IPMNs, we're recommending pancreatectomy. And then we're recommending, of course, excisions for skin nevi. So the problem is, the issue is that our technology is getting better and better and better. We're finding more and more of these precursor lesions. But I think it's safe to say that in most cases, if the story of breast cancer and DCIS translates to these other organ sites, it's very likely that the majority of these lesions, just as DCIS doesn't invariably progress, that the majority of these other lesions would not invariably progress to invasive cancer. Now, here's a slide from the JNCI about 2 years ago, which I think is really kind of at the heart of all this. So if you can imagine precursor lesions starting here, okay, and here this dotted graph is where the lesion becomes symptomatic, where you feel it, palpate it, or have symptoms from it. And the top is where this lesion ultimately results in the demise of the patient, death. So in many cases, these lesions progress very rapidly from in situ to becoming symptomatic to death. In other cases, they progress very slowly from becoming in situ to symptomatic to death. And in still other cases, they progress very, very slowly. So slowly, in fact, that competing risks kill you before this lesion becomes symptomatic. In other words, before you identify DCIS or the pancreatic cancer or whatever, you die of something else. So you never know that you had this thing progressing, and which, if you had lived longer, would ultimately have become clinically manifest and resulted in your death. And then there's another possibility. There's another possibility. The other possibility is that some of these lesions may not progress at all, and they may even regress through a process known as apoptosis. So precursor lesions are probably very active. Some progress very rapidly, some progress slowly, some progress very, very slowly, such that competing risks kill you before the lesion becomes clinically manifest. And some may, in fact, not progress at all and may even regress through a process known as apoptosis. So the point is there's incredible heterogeneity with respect to these lesions. And it's not fair to assume that they have a uniform pattern of progression. Things just aren't that simple in the human body. So this is a graph that I want to get into, but it kind of showed the progression of the lesion. We're kind of running out of time, but according to this different genetic sites, so this is the graph that I showed you early on, a similar graph. So in other words, the common assumption that we start with normal duct, go to hyperplasia, go to atypical ductal hyperplasia, go to carcinoma in situ, go to invasive cancer, and then go to metastasis is probably an oversimplification of what actually happens. There's probably quite a bit of heterogeneity, quite a bit of variation in timelines, and indeed some of these lesions, atypia or ductal carcinoma in situ, may potentially regress and pose no threat to life whatsoever. Now, the hypothesis that in fact DCIS is a precursor lesion to invasive breast cancer has been challenged. Okay? So this is a model that was developed by Sontag and Axelrod. And what they argue, and again, this is not based on biology or molecular biology. It's based on mathematical modeling. And the hypothesis has not received much press, but it's out there, and it's potentially a viable alternative hypothesis to the sequential progressive hypothesis of DCIS that I outlined earlier. And according to this hypothesis, DCIS starts, and invasive cancer starts with a common progenitor cell. But DCIS is not an immediate precursor to invasive breast cancer. What happens is you have this common cell, precursor cell, and then from this you get two separate lineages, two different cell types, one DCIS and one IDC, invasive ductal carcinoma. And these then progress separately in parallel fashion, one to form invasive cancer, the other one to form DCIS. So they have close proximity to one another, which is what we see with DCIS. DCIS oftentimes closely adjacent to the invasive breast cancer. But one is not the precursor to the other. And what the authors argue for is that the split can occur at various timelines. In other words, you can have DCIS splitting off from this stem cell earlier, and IDC, invasive ductal cancer, splitting off later. Or you can have the reverse, IDC splitting off earlier to form a separate cell line, or DCIS splitting off later to form a separate cell line. So there can be variations from this common theme. The point is, according to this model, that yes, these two lesions may originate from a common precursor stem cell, but then they diverge into different cell lines. So let's talk about treatment of breast cancer. And I think I've only got about 10 minutes, but I think it's important to kind of talk. So clearly some DCIS, 25 to 30%, 25%, 20% of DCIS does progress to invasive breast cancer. So how do we treat this disease? that in fact does progress to invasive breast cancer? Well, one way, of course, is with wide local excision. So I'm talking about the surgical treatment options here. One is wide local excision. So we would recommend wide local excision, or if you want to use the term partial mastectomy, quadrantectomy, segmentectomy, whatever term you want to use, we would recommend that in patients that have lesions confined to one quadrant of the breast. So in lesions that are confined to one quadrant of the breast, we would recommend partial excision. If the disease is multicentric, in other words, if you've got DCIS in multiple areas of the breast, then we would recommend mastectomy. So multicentricity, but not multifocality. Multifocality means that you've got multiple areas of involvement in the same quadrant of the breast. Multicentricity, but not multifocality, would be an indication for mastectomy. If the lesion is multifocal or confined to one quadrant of the breast, we generally recommend wide local excision. Should we do axillary surgery for DCIS? And the answer is no, because DCIS is a local problem. It doesn't metastasize. There's no reason for axillary surgery. The only time you may want to consider axillary surgery is if there's a high threshold for considering that there may be invasive cancer in the specimen. So for example, if you have a palpable DCIS, DCIS is very, very rarely palpable, but if you have a palpable DCIS, there's a very high chance that when you excise it, you may find occult invasive breast cancer in the specimen. Going back then to do a sentinel lymph node biopsy is often problematic because you've disrupted the lymphatics. So we generally recommend sentinel lymph node biopsy for palpable DCIS. We also generally recommend sentinel lymph node biopsy for multicentric DCIS if you're going to do a mastectomy. So again, if you do a mastectomy for DCIS, going back to harvest the sentinel lymph node is problematic because you've now ablated the lymphatic drainage between the breast and the axilla. So in patients who are going to have total mastectomy for DCIS, we would recommend sentinel lymph node biopsy. And finally, if you see evidence of microinvasion on core biopsy, so if you have DCIS, mammographically detected DCIS, occult DCIS, but on the core biopsy specimen there's evidence of microinvasion, then we would recommend sentinel lymph node biopsy because in the presence of microinvasion, there's a very high chance, very high probability, that in fact you'll find invasive cancer in the final specimen. So we would recommend sentinel lymph node biopsy in the first instance to rule out the possibility of axillary lymph node metastasis. So in general, wide local excision for localized disease, mastectomy for a multicentric disease, limited axillary surgery, because again, this is a local problem. This is a problem of abnormal cells confined to the ducts. Unless there's threat or potential risk of invasive cancer, we generally don't recommend any sort of axillary surgery. And sentinel lymph node biopsy in the three cases that we talked about. And of course, if sentinel lymph node is positive, that generally means that there's invasive cancer. And if sentinel lymph node is positive, we would recommend a level 1 and level 2 axillary lymph node dissection. I should also point out that wide local excision requires radiotherapy. Mastectomy does not. Patients who have mastectomy for DCIS don't require radiotherapy. We also now recommend for estrogen receptor positive disease, localized disease, tamoxifen for 5 years. So as it turns out, tamoxifen not only has a systemic effect, but tamoxifen also has a local effect. So we can substantially reduce the risk of a local recurrence with tamoxifen. But tamoxifen is not needed in patients who have total ablation of the breast, i.e. mastectomy, because the risk of local recurrence is no longer there. Now, there have been 5 randomized trials that have addressed treatment effects in DCIS. So we don't need observational studies upon which to base our treatment paradigm. We have good interventional studies. So the NSABP 17 trial compared lumpectomy versus lumpectomy with radiotherapy. The EORTC 10853 trial did the same, compared lumpectomy and radiotherapy. The EORTC is the European Organization for the Research and Treatment of Cancer. So this was a European trial. Again, similar to the NSABP 17, compared lumpectomy versus lumpectomy with radiotherapy for patients with DCIS. The Swedish trial, again, same as B17 and EORTC 10853, compared lumpectomy alone versus lumpectomy and radiotherapy. Now, the NSABP 24 trial took this one step further. It compared lumpectomy radiotherapy versus lumpectomy radiotherapy and tamoxifen for 5 years, 20 milligrams a day for 5 years. And finally, the UK, Australia, New Zealand trial, which is the last trial that I mentioned here, was a 2-by-2 factorial design trial. So what does that mean? That means that patients were initially randomized to either excision or excision and radiotherapy. And then the two arms were then again randomized. The excision arm was then randomized to excision versus excision tamoxifen. And the excision radiotherapy arm was randomized to excision radiotherapy versus excision radiotherapy and tamoxifen. So ultimately, in the UK, Australia, New Zealand trial, there are 4 arms to study. There was excision, excision tamoxifen, excision radiotherapy, and excision radiotherapy tamoxifen. 4 arms to study. So we really have 5 very nice trials, very large trials, looking at permutations in the adjuvant treatment of DCIS, looking at local excision plus radiotherapy, local excision, radiotherapy plus tamoxifen. Now, the reason I put this slide up is to point out something very, very interesting. So the B17 trial was undertaken from 1985 to 1990. The B17 trial had 818 patients. The B17 trial randomized women to lumpectomy versus lumpectomy and radiotherapy. After B17 was completed, the NSABP launched the NSABP 24 trial, which compared lumpectomy, radiotherapy versus lumpectomy, radiotherapy, and tamoxifen. Notice what happened to the sample size. You went from 818 patients to 1,804 patients, more than a doubling in sample size. Why? Because now, with B24, since B17 proved that lumpectomy and radiotherapy was more effective than lumpectomy alone, and since lumpectomy and radiotherapy reduced the risk of recurrence by half, you had to include lumpectomy and radiotherapy as your standard arm. And so you lowered event rates by half. If you lowered event rates by half, you automatically have to double the sample size to tease out any effects of treatment. So we've seen a dramatic increase in sample size requirements to conduct trials on DCIS. Now with lumpectomy, radiotherapy, tamoxifen being the standard treatment, and with the recurrence rates being so very, very low, it's very unlikely we're going to see future randomized trials on DCIS. Very prohibitive because of the massive sample size requirements that would have to be undertaken. Now, we always think of tamoxifen as having a systemic effect alone. In fact, tamoxifen has a local effect as well. So here's a graph that shows results of the B24 trial. Remember, B24 looked at lumpectomy radiotherapy versus lumpectomy radiotherapy tamoxifen for DCIS. And what you see is that if you have positive margins and you give tamoxifen, the positive margins are very little consequence. When I say positive margins, I mean close margins, less than 2 millimeters. Those are very little consequence. But if you have positive margins, i.e. margins less than 2 millimeters, and you don't give tamoxifen, the risk of local recurrence is much higher. So what this shows is that endocrine therapy, i.e. tamoxifen, not only has a systemic effect, but also has a local effect in the breast. So what is the treatment for DCIS? Well, with excision alone, the risk of recurrence is 25%. With excision and radiotherapy, the risk of recurrence is 13%. With excision, radiotherapy, and tamoxifen, the risk of recurrence is 8%. Now, when I say there's a 25% risk of recurrence, 13% risk of recurrence, 8% of risk of recurrence, half of these recurrences are invasive cancer, half of these recurrences are more DCIS. So with excision alone, the risk of recurrence is 12.5% for DCIS, 12.5% for invasive breast cancer. So with just excision alone, 12.5% of these patients will go on to develop DCIS, more DCIS. 12.5% will go on to develop invasive breast cancer. With excision radiotherapy, 50 centigrade of radiotherapy fractionated over 5 weeks, there's a 13% risk of recurrence, 6.5% invasive, 6.5% DCIS. With excision, radiotherapy, and tamoxifen, 20 milligrams a day for 5 years, the risk of recurrence is 8%. 4% invasive cancer, 4% more DCIS. So what does that mean? That means if the patient is optimally treated with excision, radiotherapy, tamoxifen, the risk of invasive breast cancer is 4%. Now, what's the case fatality ratio for breast cancer in the United States? By that I mean, how many cases lead to 1 death? So there are 225,000 cases of breast cancer in the United States every year, 40,000 deaths. So the case fatality ratio is about 4.5 to 1. So if a patient's risk of invasive cancer is 4% following excision, radiotherapy, and tamoxifen, that means the risk of dying of breast cancer is less than 1%. So with optimal treatment of DCIS, it's very, very unlikely that this will pose any threat at all to a woman's life. DCIS is a completely curable problem, okay? Very unlikely to have any consider. In fact, what's interesting is there's a study published a couple of years ago from UCSF showing that even though women with DCIS had a higher cause-specific mortality, that is higher mortality from breast cancer, they had a lower all-cause mortality. They were less likely to die from other things. They were less likely to die from heart disease, from osteoporosis, et cetera. So they're more likely to live longer. And if you take away the breast cancer risk, they actually have a lower all-cause mortality than their counterparts who aren't diagnosed with DCIS. So DCIS is actually a good thing to have, okay? So just to summarize, it's important to emphasize that DCIS, the diagnosis of DCIS and diagnosis of precursor lesions are very heavily driven by technology. As technology becomes more pervasive in our society and as the sensitivity of technology and of screening improves, we are more likely to see more and more things like DCIS, things like these precursor lesions. It's also fair to say, based on the autopsy studies and the histological studies, that the vast majority of cases of DCIS, and when I say vast majority, I mean about 80% of these cases, would probably never progress to invasive breast cancer. And this represents the phenomenon of overdiagnosis. Overdiagnosis may adversely affect quality of life. And this is something that I think that we as physicians need to come to grips with. We need to stop calling this thing ductal carcinoma in situ. This disease needs a complete makeover, okay? Stop calling it ductal carcinoma in situ. We should call it something else. Because carcinoma means cancer. And the word cancer frightens people. I mean, it may not frighten Lamar's or Puri or whoever, but it frightens most people. Most people are frightened by the term cancer, okay? So we need to come up with a different term to describe this entity. The optimal treatment of DCIS is wide local excision, radiotherapy, and tamoxifen. And with that, we reduce the risk of recurrence of invasive cancer down to 4%, and the mortality is less than 1%. Very, very excellent prognosis. Nobody's going to die from DCIS if that's all it is. Axillary surgery is over-treatment. It's not needed. And it should not be done unless there's a high probability that there may be invasive cancer in the specimen. So I think I'll leave it at that. Any questions?
The good news for our intern applicants is if you choose to come to this program,